Dispatch, what is the location of your emergency?
229 Washington Drive.
Okay. Tell me exactly what happened.
Sure. I'm actually a UPS driver. I was knocking on an apartment door and I heard a call for help from the neighboring apartment.
Okay.
Went inside. And
Line 595, we're en route.
Gotta be 65-ish. She's sitting in a bed in her living room. She's having a lot of trouble breathing. Doesn't seem to have AC. It's very warm in here. And the dog obviously won't stop barking. So
Are you there?
she's in rough shape, yeah.
Are you with her now?
Yes.
How old is she?
Ma'am, how old are you? She's 65.
Okay. And that's her talking to you in the background?
Yep. She's very labored, though. She's saying that she's in quite a bit of pain.
Yeah. Is she completely alert?
Yes. She's awake.
Today we ride along with Wendy and Katie. It's going to be a really great experience because Wendy has over 20 years experience and Katie has just been on the street just a few months as a paramedic. We're going to watch how two paramedics with vastly different experience levels can work together to accomplish great patient care.
Deep breath as much as you can.
In this particular case, we have a patient complaining of respiratory distress. So a very common complaint, and actually during this virtual ride-along series, we've done 2 other cases with respiratory distress. If you want to look back and check those out, they've been actually different than the one we're going to present today. So each one teaches us a little bit more about medicine and complaint-based medicine, which is really how it is that we take care of patients. Unfortunately, the patients didn't read the textbook, so they won't present like the signs and symptoms in one chapter versus another. They kind of present like real people who say, I just have trouble breathing. Let's watch this initial survey, the primary survey, as Wendy and Katie begin interviewing the patient.
Okay. Have you had this before?
Notice how the patient is thin, emaciated, maybe a little bit ashen. Can you see how she's breathing with pursed lips? She's trying to breathe, kind of bringing up her torso. And if you notice really carefully, the inside of her sternum is sucking back in because she's working hard to breathe. That means she's in distress. And both Katie and Wendy have recognized that. Wendy is trying to listen to lung sounds. Watch what's happening while she's trying to listen to lung sounds. Can you hear the dog barking?
3 hours ago and it's gotten worse?
Feeling slowly.
Okay.
Can you hear Katie trying to interview the patient so the patient is talking while Wendy is trying to listen to lung sounds? That isn't going to work very well, and in fact, Wendy, with the experience she has, can kind of say, hey, let me just listen for a little bit. Let's watch how she manages that relationship so she can get a good listen to the lung sounds.
I'm going to have you not ask questions for just a sec so I can listen to your lungs. Deep breath as much as you can. Diminished, I don't hear any wheezing.
Did you hear what Wendy just said? The lung sounds actually didn't present with any wheezes. Well, if the patient has a history of COPD, like the first responders said she did, one would expect, especially with asthma, that you would hear some whistling, some wheezing sounds, some high-pitched noises. In this case, this patient has very little lung tissue left, okay? So she is not going to be able to move a lot of air. And in some cases, if the bronchospasm, the spasm inside those bronchioles, is so great, and the alveolar space, the space inside those pockets that help line the alveoli so that we can get oxygen exchanged with air, if that is so diminished, we might not be able to hear anything. We call that a silent chest. That doesn't mean the patient isn't in bronchospasm. It just means that they're not moving enough air that we can actually hear the wheezing.
No, it's diminished. She's not getting good air exchange.
Let's take a look at how the patient is breathing. All of the elements that we see in this case are very classic of someone with end-stage COPD, meaning they're working so hard to breathe, they've actually over time compensated, their body is compensated for a lack of oxygen. And it compensates in a bunch of different ways, but they become more emaciated, as you can see with her. She's not completing full sentences, and she's a little bit anxious.
Do you know you have COPD?
Yeah,
Okay. When did they diagnose you with that?
about 6-7 months ago.
Okay, so when this first happened?
So we have to go back to the physiology and the pathophysiology of how we breathe and how disease affects that breathing pattern. So if you think of the diaphragm as a dome-shaped muscle that contracts and the chest cavity expands, the act of breathing is actually when we suck in air. As we suck that air in, then we passively let it back out. We use the oxygen and then we go, well, when air is trapped inside because the bronchioles and the main bronchuses are spasming, or we have very few pockets of alveoli left because they're all consolidated, called atelectasis, well, we have a lot of dead air space and we're able to get air in. That's an active process. We suck the air in. But when we try and exhale it, it's like we're blowing out through a straw. And so it's going to take us a little bit longer to get that air back out. That's what's happening with this particular patient.
We'll give you a side rail to hold on to. There you go. How do you feel sitting at that angle? Do you want up more?
That's fine.
Okay.
Just give me something.
Do you notice as they're putting on the nasal cannula that it has a little lip? That's a special smart cannula that measures inline end-tidal CO2. It's essentially catching the end of the expiration and measuring the gases that are exhaled at the end of breathing. That helps us figure out exactly what amount of end-tidal CO2 is being produced. Think of end-tidal CO2 as sort of the smoke from the fire of life. As metabolism is going on in your system, you're exhaling the smoke back out, and the end-tidal CO2 tells us about how well you're metabolizing, but also how well your lungs are exchanging oxygen with carbon dioxide.
Nice easy breaths. We're gonna get you to the hospital here.
Try and breathe it in your nose. That oxygen will help.
Yep.
Notice how the patient, even though she's anxious and appears to be air hungry, is still moving a large amount of air in her chest. This is very helpful. We can see that air is going in and out, and at the end of the day, that's the basic assessment that you need to do, chest rise. So she is moving fairly good air, even if there's just a small amount of alveoli inside getting the gas exchanged. We're going to help correct those gases, but at least she's still moving air.
We're gonna give you a nebulizer, okay? Have you had one of those before?
I take 3 of them.
Okay. Do you take 3 of them every day?
Every 6 hours I take one, and
Okay.
every 12 hours the other.
And they haven't been helping today so far?
No.
Do you see the shark fin waveform that's actually on the monitor? So when we suck the air in, you can see an immediate straight line on the monitor. But if there's a prolonged exhalation, that means that when we're blowing the air out and we're pushing against that straw, then there's a curve and it takes a little bit longer to actually get it out. Well, the end-tidal CO2 monitor is a great tool to be able to differentiate between COPD type mechanisms of the pathophysiology of respiratory distress and something that's less about air trapping and more about congestion, like, for example, congestive heart failure. So by analyzing those waveforms, looking at the values and comparing them and understanding what the patient's going through too, getting the history, that end-tidal CO2 can be very, very helpful.
Some of those medications you take are a steroid, which are a little bit different. They're longer acting than what we're going to give you now, okay? It's been fairly humid out too. Is that usually a trigger for you?
Yes,
Do you have asthma also, or just
I think
COPD?
so.
Did they tell you have asthma, or just COPD?
It's a COPD.
Okay.
I'm going to give you the snip treatment. All you do is suck in here and breathe out. You're not going to see any medication because it only gives you the medication when you breathe in. Okay? It gives you a little bit more of the medication than you're probably used to.
Yep. See how this ball goes down? That means you're getting the medication, okay?
We're going to monitor breathing very carefully while we transport this patient and continue to treat them, and we will escalate our care as needed to make sure we're compensating for her respiratory effort. Right now, she's moving enough air. The crew still has one more tool available to them in the event that she can't get that air in, and it's called CPAP, Continuous Positive Airway Pressure, and we can attach a mask that's going to force air in and open up those alveoli. It's very helpful to breathing, and we use it for both CHF patients and COPD patients. We just don't have the high respiratory rate and some of the other serious signs of distress that really warrant it for this particular patient. The nebulizer is working.
We have you all strapped in here, okay? It's going to be bumpy though, and we're going to have our lights on, so it's going to be a little bit bumpier than normal, okay?
650 code 3 to Mercy.
We're about 5 minutes out with a red patient, 67-year-old female, coming to you today for COPD exacerbation. She is very tachycardic, 140s to 150s right now. Pressure is high, 192 over 114. She is moving better air now with the nebulizer. We will be to you in about 8 minutes, 5 to 8 minutes.
Field providers have a difficult decision to make. Do the best job you can at determining whether the patient really needs emergency transport. It can be very dangerous to transport somebody lights and siren and push the limits of speed and safety. But if the patient really needs it, that's what you'll need to do. Always think, do I have 5 more minutes to transport this patient in a routine mode?
At the end of the day, these patients with respiratory distress need us to alleviate their respiratory effort in whatever way we can, whether it's by supplemental oxygen or mechanical ventilation if needed, and identify the cause of the respiratory distress. In this case, we were pretty focused on COPD and end-stage emphysema. But did you notice how the patient is taking Lasix? So we always have to think, could this actually be congestive heart failure? Because Lasix is a diuretic used with people who have high blood pressure and failing hearts. It's always good to keep a wide differential, keep your antennas up, and make sure you don't get caught missing a diagnosis because you had tunnel vision for something else.